non-healing foot ulceration in a 79-year-old patient with all the comorbidities that you'd anticipate somebody with a foot like that would have. He had previously undergone a right popliteal artery angioplasty, but you imagine why somebody in this situation would continue to have a wound. And it looks like there's a stent there too, but
I think I see a stent in a popliteal as well.
Yeah, so you can see long segment AT disease and some slow flow through that posterior tibial artery. And I primarily used the E8 of 4x80, delivered 200 pulses over 3 treatment areas, and it was easily delivered. And more importantly, I didn't have to pre-dill, right? You can see a nice result here of brisk flow through that anterior tibial artery and posterior tibial artery.
So that's a really good result. I'm just going to ask you, from a technical standpoint, delivering this over a 014 wire, which 014 wire do you typically use?
Generally, I cross with an 018 system, use an 018 support catheter, and then I exchange for a cheap but robust wire. I think the SpartaCore is a very nice working wire for pretty much most of my interventions. I used to like using the Viper wire because I like that additional length, right? So you never have to worry, especially if you're treating down distally, about sort of running out of wire. But the SpartaCore for a proximal tibial lesion, I think, works really well. What do you like to use?
I agree. I cross with a 018, depending on what it is, usually a glide wire advantage, and then switch over to a 014 system, a nice support wire to be able to get my catheter there. Also looking at this, and, just from the x-ray films, you can see that the tibials are really calcified. Now, with this E8 balloon having such a longer length and a longer treatment length, it's really nice because let's say the whole anterior tibial artery was diseased, you can now go straight with that E8 catheter and use IVL for the whole thing. Before, what would you have done before having E8? Would you have just went with an S4?
Well, I think my next case really illustrates that really nicely. Okay. And Kyle hasn't seen the slide, so, we're super happy.
Pop quiz.
Right, so tale as old as time. Patient with a non-healing wound. This patient was referred to me actually because this patient was unable to get inline flow to their foot. What was unbeknownst to me at the time of referral is that this referring physician ended up putting a stent in the TB trunk into a collateral, and we'll see that shortly. So you can see here, the aortoiliac segment was fine, the femoral popliteal segment was fine, but you can see here an occlusion of the tibial-perineal trunk with a focal stenosis, no obvious origin of the anterior tibial artery, long segment tibial disease with extensive collateralization, and maybe the wisp of an anterior tibial artery at the ankle.
Maybe a wisp as it fills into a lateral tarsal, but otherwise.
Yeah, when I saw this, I thought this was a little anomalous from an anatomic standpoint. It looks like this patient doesn't have a DP. They have a medial tarsal and a lateral tarsal.
Yeah.
So obviously CLI case. In my opinion, I think these are the most challenging types of cases, right? You got patients with paramalleolar disease, no origin of the anterior tibial artery to access. So if I'm going to deliver something, I'm going to have to do it from below, or I'm going to have to involve pedal access. I don't know if I'm bold enough. I don't know, Kyle, would you be bold enough to sew to that dorsalis pedis, do it bypass to the DP?
I might be bold enough, but I would be worried about the patency and how long it actually stays open with that outflow.
Yeah.
How diseased that vessel is.
So I cross from below, and you can imagine, right, this is going to be a long segment angioplasty, likely to have some component of subintimal traversal. So not a good candidate for atherectomy, in my opinion, and not something I thought that I would be able to deliver a Shockwave balloon on primarily. So I used conventional angioplasty, and you can see here in the second image an area of significant stenosis, right? That looks horrible, right? And I ballooned that over and over and over again with conventional balloons. I think this may have been my first E8 case. We had it, we delivered it. It was delivered very easily, but have to say, you have through and through wire access, you can pretty much deliver anything. But after 4 cycles easily delivered, you can see a result that I'm pretty proud of, right? We can see excellent expansion of that proximal anterior tibial artery, and we can see flow through that anterior tibial artery into the dorsalis pedis, right? And filling of those sort of medial and lateral tarsal arteries. And my last case is something a little bit more conventional, flush SFA occlusion, primarily treated with an E8 and a subsequent 7mm drug-coated balloon. And I think this is the type of picture that, isn't going to be someone who's got a wound, but this is somebody that you know you've been able to treat and not really burn any bridges subsequently, right? And that's all secondary to the ability of the E8 catheter to be delivered without the need of atherectomy, without the need for pre-dilatation, and then the ability to treat these patients chemically with drug-coated technologies.